Okay, everyone, let's get started. We're going to focus on the elbow this morning, and there's obviously a lot more to talk about than we can cover in 30 or 40 minutes, but we will get through as many pearls as I can think of, okay? The QR code is the handout. I think Brandy's got a PDF that she can distribute to everyone also, but if you want to get it right now, you can use your phones and take a picture of that QR code. I'll show it on multiple slides. So this is where we're going to go. We're going to start looking at some normal and abnormal elbow anatomy by ultrasound. We're not going to cover the entire 10-point elbow exam, but we'll hit the most common things on the medial and lateral elbow. These are the top 10 elbow structures that we cover in our course, but we're only going to focus on the lateral and medial elbow and a little bit on the distal biceps today. So let's talk about lateral elbow anatomy, commonly known as tennis elbow, of course. This is the common extensor tendon origin. The primary tendon that is always a test question is the extensor carpi radialis brevis, is the one most commonly involved with pain and tendinopathy on this side of the elbow. A little bit deeper is the radial ulnar collateral ligament, and we can visualize that very well on ultrasound as well. And then, of course, the primary joint on this side is the radial head and capitellum. So this is a ultrasound image on the top left here that hopefully most of you have seen by now. Remember, the superficial one half of that slope, I'm not sure if my pointer is showing, but the superficial half of this slope is the common extensor tendon. That's where it says CET on the image. That's common extensor tendon. And so when we're looking for hypoechoic changes or dark signal in the ultrasound image, this is the region that we're looking for that hypoechoic signal change right up in here. If we're looking for changes in the ligament, we're going to look down closer to the joint down here where it says RCL for radial collateral ligament. Sometimes we'll see changes all the way through, and that usually means that it's a more severe case of tendinopathy because it's grown to involve the collateral ligament as well. The normal ECRB is about 3 to 4 millimeters thick. A typical sign of tendinopathy, in addition to the hypoechoic signal that we've talked about, would be a thicker tendon. So if that ECRB is 5 or 6 millimeters thick, a lot of times that indicates inflammation, and that can be another tip-off that there's pathology there. Let me go back here. So here you can see an example. The double-headed yellow arrow is right at the midpoint of the extensor origin. And if this measure is more than about 4 millimeters, according to some authors, that's a sign of pathology. So that's one objective way to measure and to make a diagnosis of lateral elbow tendinopathy. When it looks this bad, it becomes even more obvious. Here, if you look on the left side, you can see this broad area of hypoechogenicity. It's just darker than it should be. And remember, with ultrasound, if you're ever not certain, use the opposite elbow as your control and see if there's a side-to-side difference in the appearance. Some of the other tip-offs of tendinopathy in general apply at the lateral epicondyle as well. So if there's a cortical break, meaning if this bright white line has a break in it, like at the point of these arrows, that's a sign of some microavulsion fractures potentially. And that can be an indication that there's been some repetitive stress and trauma at that site, which would also strengthen your argument for tendinopathy. This is another example. This is radial head here. Here we see the lateral epicondyle, and here we see this hypoechoic region. We can use Doppler. We don't have to use Doppler, but if you want to check for increased vascularity, then Doppler is a nice way to again, pick up a side-to-side difference from the symptomatic side to the asymptomatic side. So if the right elbow is symptomatic and the Doppler looks like this, and the left lateral elbow is not symptomatic and the Doppler doesn't light up, that also strengthens your diagnostic argument that you've got some tendinopathy going on there. In terms of ultrasound-guided injections, we're using ultrasound for all of these lateral elbow injections because we can see the needle, we can see the pathology, which means that we can put the needle where the pathology is. And when we're injecting, whether it's steroid or PRP, or for that matter, even bone marrow concentrate, we'd like to put it exactly where the pathology is. And I think everyone at this point knows my preference and bias against steroid for tendinopathy because of its potential harmful effects. So we're primarily talking about using PRP most of the time. Here's an example using a 25 gauge needle. The volume is relatively low. Even though we typically draw 60 cc's, we're going to concentrate down to 1 or 2 cc's for these elbow injections. If you get into the 3, 4, or 5 cc volume, it's going to be more painful. And the only time I would even really go to 3 cc's would be if you've got a significant injury to the extensor carpi radialis brevis, and you're putting that extra PRP more at the origin of the muscle or at the muscle tendon junction. The clinical image here on the right is showing an in-plane injection. So it's a long axis view of the ECRB origin, and it's an in-plane injection, meaning the needle is going to be visualized as a bright hyperechoic structure. If somebody's relatively small, then you can use the edge of the transducer as your entry point as you aim towards the proximal epicondyle. If someone has a little bit more muscle or is a little bit larger elbow, you may have to do a little bit more of an oblique injection. It can still be in plane, but your needle entry point may be a little bit closer to the epicondyle. And of course, you can also do these out of plane as well. And if you haven't done that and want to see that, then make sure and get with me next time I'm around. A lot of times when we start to inject, we may see more damage than we anticipated. So here's an example with an in-plane injection. You can see the bright white needle. And as we inject a little bit of, whether it's, in this case, a diagnostic injection with normal saline or using an orthobiologic like PRP, we can see that this origin is actually detached. And so it's a much higher grade partial tear than we anticipated. Now, we can also do these injections out of plane. We can either approach the lateral epicondyle out of plane, or we can approach the joint out of plane. So here, this is a long axis view, but notice in the clinical picture, the needle is coming in out of plane, not at the edge of the transducer, but right at the midpoint of the transducer. And so this white circle is just meant to illustrate what the tip of the needle would look like once you visualize it into the joint, for example. A lot of times with a larger elbow, this out of plane approach is nice because it's a little bit easier to manage, to get this basically right over or right under the central part of the transducer and bring your needle straight down until you hit bone. And that way you have a hard bony stop and you can inject your PRP or what have you right there. Radiocapitellar joint, you can approach this proximal to distal, or for that matter, even distal to proximal. I use small gauge needles, 25 gauge needles around the elbow. If you've seen me do this procedure, or if I've helped you do it, you know that I don't like attaching the syringe to the needle until we have the needle placed exactly where we want it. The needle is the key. So once you have the needle exactly where you want it, your job as the proceduralist is to hold the needle in place as either you or someone else then attaches the syringe. And that makes your injections much more pinpoint, much easier to control. So in the posterior elbow, we can visualize the triceps, the olecranon bursa. Some of this just goes back over rotator cuff tendon tips, which are applicable to tendon insertions anywhere. So here we have the triceps tendon. It inserts into the olecranon. Like with any other tendinopathy, we're looking for hypoechoic changes if we're looking for partial thickness tears, whether it's rotator cuff, triceps, extensor carpi radialis brevis. And so this would be a distinctly abnormal appearance with all of these dark areas in the tendon. This would be yet another distinctly abnormal appearance of a triceps because there's just chaos here. There's just no organized signal, no organized linear signal of tendon fibers inserting on the olecranon. And then, of course, the other big tip-off here is that the olecranon, that clinical margin, that cortical margin, excuse me, is broken, right? You can see the white line here. There's a break right here. And you see that there's clearly been some type of avulsion injury at the triceps insertion to the olecranon. If we have an indication to inject the triceps, you can do a little bit of an intratendinous injection. You can do this in plane, relatively straightforward. The red dot on this clinical image is where the needle would come in if you're using a proximal to distal approach. Like most solid tendons, it's not going to hold a lot of volume. The rest of your PRP would be outside the tendon, but just adjacent to it. If you wanted to do this using a long axis view of the triceps, but out of plane, you'd have the exact same image, but now look what happens to your needle insertion point. Instead of being at the edge of the transducer, it's now right at the midpoint. And that would allow you to bring that needle straight down to bone right here. Positioning is typically with the patient prone, as you see here. We can do this in the short axis with the transducer aligned across the elbow like that, or we can do this in the long axis. And so there's multiple ways to do it. We've talked about that before, and we'll continue to go over that if you have any clinical questions about how to position for these injections. On the medial elbow, the primary things we're looking at are the ulnar collateral ligament and, of course, the common flexor tendon, which is what we call golfer's elbow. Ulnar nerve is over there too. We're not going to focus too much on that this morning. So this looks a lot like the lateral elbow, but there's one ultrasound tip that I would give you, which is that when you angle the transducer towards the thumb, that's going to give you the common flexor tendon picture. Common flexor tendon is going to be along the superior aspect of this slope. When you get down to about the midpoint and down closer to the joint, if you rotate the transducer so that now you're aligned along the ulna instead of pointing at the base of the thumb, that's going to bring the ulnar collateral ligament into view. You typically will not see the common flexor tendon and the ulnar collateral ligament on the same screen. You have to pick which one you want to see. Notice the patient positioning, laying on their side. With the elbow aligned like this, it's pretty easy to do some subtle or gentle stress testing to check the ulnar collateral ligament. You can bolster the elbow on a towel or on a pillow, primarily designed to keep the patient comfortable. Here's a dynamic image. Here you can see the flexor tendon here has tendinopathy. See these hypoechoic changes? Now, if that doesn't make sense to you, you're not really seeing that. Just remember that this is a patient who's sore right now. So you've already got one tip, and that they're coming into doc with a complaint of medial elbow pain. And then you put the ultrasound on the elbow and you see what looks like, yeah, it could be normal, maybe not. But if you're not sure, look at the other elbow that hopefully doesn't hurt. And you'll see that this appearance will be quite different from the other elbow that's not sore. This appearance will be darker. It'll be thicker on average if it's a relatively acute symptom. And that side-to-side difference when you don't have a lot of experience really helps you make the diagnosis. And so this would be normal. You can see the tendon here coming off of the medial epicondyle. Abnormal, this flexor tendon starts to get thickened. Notice how compared to the picture on the left, which is more hyperechoic, this is darker. You kind of lose that hyperechoic signal right about here, a little bit to the right of that yellow arrow. And again, don't forget to do side-to-side comparison if you're not sure. Now let's look at the ulnar collateral ligament. This is doing a little bit of stress testing on the elbow, and the ulnar collateral ligament is a triangular shaped ligament that runs right next to the joint and occupies this region right here. Let me play the video again. So see, as we stress it, it's opening up a little bit here. It really shouldn't open up at all, really. Once you see 5 or 6 millimeters of opening with a little bit of valgus stress testing, that's for sure pathologic. Now, no one with the UCL tear should go straight to surgery, in my opinion. Everybody deserves at least 1 or 2 injections of PRP, unless the UCL is so destroyed that you're looking at the bone, which is obviously a bit of an exaggeration. But the UCL repairs and the incidence of UCL repairs is going to plummet as people do more and more PRP, because PRP works for the vast majority of UCL ligament tears. We'll talk a little bit about distal biceps here. Remember, the biceps is a supinator, and remember that the biceps tendon here at the elbow inserts on the radial tuberosity, which is about 2 centimeters distal to the joint. And so with that in mind, if you can find the radial head here, you can use the legend on the side of any ultrasound screen to see how much distance you need to go to measure about 2 centimeters. And so if that's the radial head, you go about 2 centimeters here. You should start to see these fibers of the distal biceps tendon inserting on this little prominence on the radius. And so sometimes you can do a little extra supination and pronation, and that will bring that tendon into view for you. Remember, we do not inject the biceps tendon through the antecubital fossa. We have a different approach that we'll show in just a minute. So there's the biceps tendon there inserting. Tendinopathy, like tendinopathy every place else, will just look darker. It'll be more hypoechoic. You'll lose the normal architecture. Here's another example of a complete tear. And this is what my faculty that talk about this in the course like to call chaos. You see a little sliver of biceps tendon, and then from here down to the bone, it just looks like a small grenade went off. There's just nothing organized about it. And especially if you've got the clinical story, they've got some, ecchymosis and bruising, and they're weak in supination. This is really all the imaging you need to make the diagnosis. And so that's where it should be, and that's where it's not. Now, to do injections for the biceps, we use this. Let me turn sideways. We use this type of orientation of the elbow. So the elbow is flexed and the wrist is pronated. And when you do that, if you look at these images on the left, you can see what that does to the insertion. It brings the insertion into a plane that is very safe to inject. And so when you do that, here's the radial tuberosity. This is just right here is the biceps tendon, and this is the needle coming in. And so we're injecting just above the biceps tendon, and that will travel all the way up the tendon, all the way up to the muscle tendon junction. And it's a much, much safer approach than going through the antecubital fossa. And so this is what it looks like. The only criticism I would have of this clinical picture is I would want the wrist even more pronated to make sure we have a good image. But the bottom line is, once you can see the biceps tendon right here, which is just this little area just above the bone, your target with the needle is just like this. This picture is just perfect. And that allows you to do a very safe, very quick, and minimally painful distal biceps insertion injection for distal tendinopathy or tendonitis. So we're going to rapidly switch gears here and talk about some of the evidence for using regenerative medicine for elbow pathology. Just a quick note about injectable allografts. Sometimes I get texts or emails from some of you asking about, what the current state of the art is here. And I will just reinforce that right now in the United States, just say no. If it's an injectable product that doesn't come from the patient, we cannot use it until the FDA clears it for a drug indication. And that's been the case for sure since June of 2021. Just this past May, the FDA made it even more obvious in a letter to a company that's based out of Dallas here. And what they did was they changed the language. It was real subtle, but they made it really obvious that if you are using umbilical cord and you're not replacing umbilical cord, then it's a drug. If you're using amniotic membrane and you're not replacing amniotic membrane, then it's a drug. And so they've made it really obvious that homologous use is not just cushioning or growth factors. It truly has to be replacing the and restoring the function from whence it came. And so that means putting amniotic fluid in a knee is a no-no. Putting umbilical cord blood at the elbow is a no-no unless you normally have umbilical cord blood in your elbow. And so this is now exceedingly obvious that this is the current regulatory status for these allograft products. So I put a couple articles on using PRP for elbow tendinopathy and ulnar collateral ligament. I put Alan Mishra's article here from 2013 on because it was really the first best PRP article in sports medicine. And so it's a landmark article, be in every elbow journal club that's talking about regenerative medicine. And basically, Alan showed that adding PRP to a needling of the lateral epicondyle significantly raised the success rate. And that study prompted a change in clinical practice and many, many, many further studies. This 2019 study is nice to reference because it's a meta-analysis, includes the best studies to date up through 2019. And what they showed in all these studies that they included was that PRP versus steroid was better than steroid. And so, and it was better in a very statistically significant way. And this included long-term functional improvements. And so this meta-analysis further bolstered the argument that PRP is better than steroid for tendinopathy at the lateral elbow. For ulnar collateral ligament, this paper that came out last year is why I say that everyone deserves PRP for a diagnosis of a UCL tear. And it's because we can get 72% of these people back to throwing, which is about the hardest thing you can do to the elbow, about 72% after 1 or 2 injections, and most of them after 1 injection. So you still have to be the clinician, you still have to be the doctor. If the MRI scan shows that that UCL is completely exploded at both ends, origin and insertion, those people don't do well with PRP. But if that same person happens to be a 78-year-old who fell down and that's what they have, I would certainly try PRP first. Okay, so you have to, again, that's the art of medicine. You have to tailor your treatment to the patient in front of you, not necessarily to the imaging. But just know that PRP works for UCL pathology. And if somebody's young and a thrower and they hope to get back to throwing or any overhead sports, you better try PRP first. Bone marrow concentrate. There is not a lot of data here, so I'm going to run through the best data showing that BMC can be helpful for elbow pathology. I'm going to blow by this because I think we all know that BMC can be safe and that it's regulatory compliant. I want to hit one little bullet point, which is, remember, when we're talking about orthobiologics to patients and talking about regenerative medicine, always, always, always talk about BMC first. On your whiteboards and in your chalk talks, always talk about BMC first, even if that's not the most common thing we do for a particular pathology. And there's a behavioral science reason behind that, because we want patients to pick what we think is the best for them. And if we're talking about PRP because we think that's the best, they will understand that better if you talk about BMC first. And we can talk about that in more detail if you'd like. And so here's the best paper showing that BMC is effective for elbow tendinopathy. It came out 6 years ago. And these are some Indian authors. It's published in a little known journal of natural science, biology, and medicine. But this is really the best one. And so for this reason, this is why PRP is the most common thing I do for tennis elbow or golfer's elbow, because we don't have a lot of data. I think BMC works, but there's not a lot of clinical data. So let's look at this. This study, their protocol is pretty simple. Let's take 30 patients. Let's use iliac crest. And let's follow these patients for 3 months and see how they do from a single injection of bone marrow concentrate. Pretty simple. The intervention, they use anterior iliac crest. They use 10 cc syringes, which is great. They drew 10 cc's of bone marrow, which, if you know me, I don't think that's great. From that 10 cc's of bone marrow, and after their centrifuging, they injected 4 to 5 cc's of bone marrow. And you just heard me say a little bit earlier that no more than a couple cc's. So that's a big volume. They added 1 cc of lidocaine to the bone marrow concentrate, tactical error, which we'll talk about. And they didn't use ultrasound guidance for the injection. So the intervention has some holes in it, but that, at least they described it so we know what they did. Their results were pretty good. There's an elbow tendinopathy scoring system that you may not be familiar with. It's called the PRTEE score, PRTEE. It's pretty simple. It runs up to 100, where if someone's 100 out of 100, that means their elbow needs to be cut off because they're in mortal pain. And so these patients came into the study with a score of 75, which is bad. 3 months after this single injection of bone marrow concentrate, their end score was 15 out of 100, which is good. 0 is a normal elbow. And these results were highly statistically significant. And of note, they did lose 4 patients to follow up in just 3 months, which is actually pretty high loss to follow up, in my opinion. If I can't get people to come back and see me in 3 months, they don't all like me. Okay. And their conclusion is here, which I think is fair. Treatment of tennis elbow patients with a single injection of bone marrow concentrate showed significant improvement in short to medium term follow-up. I would call this relatively short follow-up. So in their study with their protocol, I think they did show that people got better, but it was purely a clinical outcome study. And so here are the criticisms. On the left, these are the author's own criticisms of their own study. I've identified 10. It's a small n. There's only 30 patients, and they lost 4 to follow-up. That makes it a level 4 study. Number 2, there's no control group. It would have been nice to have 30 people where they either injected steroid or placebo, or just that they followed with PT. Number 3, there's no imaging. So before the procedure, they may have had it, but they sure didn't report on any MRI scans or ultrasound imaging pre-procedure. So we don't really know what the pathology looked like and what it was. Number 4, they only drew 10 cc's of bone marrow. And so you guys know, if you're playing poker with me in this regenerative medicine game, the ante is 60. So even for tennis elbow, if we're using bone marrow concentrate, we're going to draw 60 cc's of bone marrow. We're going to concentrate it back down to 2 or 3, but we're still going to draw 60. And that's going to give us a much higher count in terms of our cellular content. And if we're talking about PRP, that's going to give us a much higher platelet dose. So they only drew 10 cc's. And from that 10 cc's, they injected about half of it. And that's a large volume to put at the elbow. I'm sure that all 26 of these people hurt a lot for a while. And so that's why I prefer to concentrate into a smaller volume with a higher dose. Imagine if we drew 60 cc's and injected half of that, 30 cc's. It just doesn't work. Number 6, they added lidocaine. We do not use lidocaine. We sure don't add lidocaine to any syringe that has an orthobiologic in it. Okay. We just don't do that. The best data suggests that that is a tactical error and can make whatever you're trying to do not work. So we can use lidocaine at the skin, especially if we're going into a joint. If we're doing something that's extra articular, like tennis elbow or golfer's elbow or the ulnar collateral ligament, I prefer to just use ethyl chloride and use a 25 gauge needle. I haven't lost a single patient doing it that way. They don't even use profanity most of the time. They did not do any bone marrow concentrate analysis, so we have no idea what the CFUs were. We don't know what the platelet count was in the bone marrow concentrate. And so that's a relatively big gap in their analysis of the procedure. They did not use ultrasound guidance. It was just a palpation, show me where it hurts and put the needle in there. And then they only followed people for 3 months. That's not that big of a deal because I think people should be better by 3 months. I tell people by a couple months if we're doing a high dose PRP injection. Um, but with these procedures, it would be nice to have a 12-month follow-up just to show the tendon that nothing happened to the tendon, like you didn't get heterotopic ossification or something else weird at a year. And then finally, they had no post-procedure imaging, so we don't know what it looked like before or what it looked like after. So thank you very much. Hook up with me on social media. LinkedIn and YouTube are the big ones. Remember that on YouTube, I've got a doc-specific playlist that I'm updating as much as I can. There's the QR code there for the handout for this talk. And as always, I'm here. Just contact me if you need me. Thanks.